Okay, thank you. So we're back live, folks. Here comes Kelly Dougherty.
Good afternoon.
Hi, Kelly. Thank you for being here.
Sure.
We just started taking testimony on S36 from downstairs. And thank you both for being available on such short notice. We really appreciate that. As I was just sharing with Monica, our schedule here is a little bit unpredictable. And we thought when we made up the agenda that we might be having more floor time, and we didn't. So we said, well, we're working on these 3 bills, and so let's see if we can find some folks who will come and accommodate that. So really, I very much appreciate the fact that you were able to be here. So thank you very much. The floor is really yours to tell us what you, I guess, are expecting, or if this is what you were expecting. And I know there was a question asked yesterday that we received a response to. I sort of like asked it in general, but Monica, being as efficient as she is, followed up on the request, and that was about the prior authorization question previously. And so why don't I turn the floor over? I'm not sure who's going to speak first. Monica, you're going to go first?
Yeah, sure. I can get us started, and then I'm going to leave it to the Deputy Commissioner to speak more about the logistics of this work and kind of the history, which might be really helpful.
Thank you.
Yeah, this bill was, for the record, Monica Ogilvie, State Medicaid Director from the Agency of Human Services. Thank you for having me today. This bill was originally introduced and it looked quite different in the Senate, and it was really trying to get at what was perceived as a limit on the length of stay for individuals that need that highest level of residential treatment for substance use disorder and co-occurring mental health disorders. And when we spoke with the committee more and tried to understand what really is the problem you're trying to solve here, because generally speaking, we don't usually legislate things like length of stay for clinical services. Usually that's really determined by a clinician who's looking at what would be in the best interest of the patient that they're treating or the person that they're trying to support. And so they said, well, we're really hearing and understanding that people don't have access to services at that highest level residential care for as long as maybe they need. And so as we dug into that a little bit more, we understood that there was maybe some misinformation or misunderstandings out there about a 14-day limit of service. It's not actually true. The Deputy Commissioner can definitely go into more detail about that. But then we said, okay, how can we actually use legislative mechanisms to achieve the problem you're trying to solve here? And what we landed on was perhaps it's the way in which we are paying providers that is somehow creating some type of barrier in their ability to deliver these services and cover their costs for doing so, because this is complex work with complex individuals. And so that's where we landed on maybe what we need to do is reevaluate our methodology, how we pay providers, and how much we pay them. And as you know, we can't necessarily commit to paying them more money, but it's really an important step, very similar to H13 that you introduced, to look at how we're paying people through study and consistently and transparently update what those rates should be based on things that change in our environment. So that's where we landed in the bill, and it feels much more directionally appropriate. And I will say it was something we were doing anyway, like we talked about in H13. We last updated the payment methodology for residential treatment in 2019. So we're due to reevaluate it. And this is sort of part of our process. The last thing I'll say about this is we also recognized that part of the conversation and the narrative out there about people not getting to stay in treatment as long as they needed to may have something to do with we don't have access to the continuum of full services of care, maybe in the robust manner that we wish that we did. And so there's a high level of treatment for residential treatment, but then there are also lower levels of treatment, which makes a lot of sense, right? You get stabilized at that high level. Hopefully that's where you spend the least amount of time. And then where you really start doing your healing and your growing and your recovery starts in lower levels of treatment. So part of our SUD, or substance use disorder continuum of care proposal that we've talked about with this committee before, is really to try and flesh out and build that continuum of care in a much more robust way so that people have the access to the right service at the right time in the right place and they're not stuck in any place that they don't need to be longer than they don't need to be there. So generally, overall, we're very supportive. We're doing it anyway. Feels very much in line with age 13 as well. I'm going to turn it over to the Deputy Commissioner to add some additional detail.
Yeah, sure. Thank you, Monica. For the record, Kelly Doherty, Deputy Commissioner at the Department of Health. And a couple of things that I'll add is one, I want to emphasize what Monica said about there not being a 14-day limit. There is no Medicaid limit, and it is driven by clinical decision-making. So, and I also want to emphasize that there's no evidence base for longer stays in residential treatment being associated with better outcomes. So what there is evidence of, however, is that the longer someone is engaged in treatment, so that could be intensive outpatient treatment, treatment at the hub and spoke. So it's not just about residential treatment. There is a whole, continuum of substance use treatment services, and really just engaging at whatever level is most appropriate for where that person is in their journey is what's going to lead to success. So I think that this bill was a good opportunity to do some education around that. And also, to try to myth bust this 14-day narrative. And like Monica said, we wouldn't want somebody to be in that highest level of care for a super long time. It's sort of akin to when you're in the hospital, maybe with an injury or after surgery, you're going to step down as soon as it's safe to do so to a lower level of care. So if you think about that analogy, I think it helps to make sense of the system. So I'll agree with Monica. We're very happy at the health department with how this bill has evolved, and look forward to, helping in whatever way we can with the rate analysis that will happen as a result of this bill, should it pass. And I'll pause there to see if anyone has any questions.
Thank you. Just to confirm, so the bill is specific to referencing what you both had just said in terms of the healthcare professionals' determination about the length of stay that's clinically appropriate for the individual, and that there is no specified 14-day limit. I have to tell you that the courts believe that too.
I know.
And that's part of where this has emanated from. And so I'm not sure what kind of education process that we can do with the courts so that they understand. Now, I think that and so related to that question, and then I'll get to my other one. So right now, there is not a prior authorization for inpatient residential substance use treatment. Is that correct? Is that what I understood from the email?
Correct. Yeah,
okay.
That's correct.
And so how does that process work? So is there a minimum stay that a person has? And then it's reevaluated, or it's just they evaluate it as as the person is there and monitoring their progress?
It's individualized to the person. So when somebody comes in to residential treatment, there is a treatment plan that's based on, the substance of concern or substances of concern, any comorbidities or co-occurring medical or mental health diagnoses, any kind of other things that might, impact their treatment plan. And then it's really driven by the progress on that plan when somebody is discharged. There is no minimum, and there are often people who come in and stay for a day or two, maybe at the pressure of their loved one or family member, and say, I don't want to be here, and they leave. So it really runs the gamut. We see people who are in for a day. We see people who are in for 45 days, and it really is dependent upon the person and their progress on their treatment plan.
Go ahead, Representative Garofano.
Thank you. Do you have data on like how long the average stay is?
We do actually, and I can share with you a slide deck that I did in Senate Health and Welfare for testimony on this bill that includes that information. So I'll forward that to the committee
That'd
assistant.
be great. Thank you.
Thank you.
And
So
just
I'm
as a-
trying,
oh,
I was just gonna say, I'm trying to understand the differences, and maybe you can maybe give us examples. So it identifies high intensity residential treatment and low intensity residential treatment. And are those in Vermont at least provided by the same entities, or are they different?
So the high intensity residential treatment is 24/7 medical monitoring. So they have 24/7 nursing care, you know, with physician sort of backup. And those are Valley Vista and Serenity House. So, and I'm sure you're familiar with those entities. The low intensity residential is clinically managed. So there's no medical monitoring involved. So it's really counselors, maybe other types of staff that do, other kinds of programming. And folks tend to stay there longer because it's not a medical environment. So we have 2 locations that provide that level of care. They are called Grace House and McGee House. They're both in Rutland County, and they're operated by the organization Recovery House, which also operates Serenity House. So a lot of house names in there.
Right.
So we do have those here in Vermont. One of the McGee House has only been open for about 3 months. And so we're sort of monitoring the uptake in those lower level so that we can assess how much more capacity we might need at that level of care.
And that both of those are Medicaid facilities? They accept Medicaid
They accept
patients?
Medicaid, yep.
Okay. And I guess if I'm thinking and, thinking back to the multiple meetings we had with the federal court folks, and I look at the high intensity medical monitoring at Valley Vista and Serenity House, and then what they had identified as missing was that next level down. And and would you say that the Grace House and McGee House is comparable to what they would have been
Yes.
expecting?
Yes.
And I think even Dr. Levine acknowledged at that point that we had insufficient resource at that level. And so it's good to hear about McGee House being a relatively new program. What kind of occupancy are you seeing in terms of Grace House and McGee House?
I can tell you in one moment. It has not been 100% full. And that might partly be due to, so McGee House kind of did like a soft opening because they wanted to just make sure that they had all of their things in place. But we look at those, the utilization numbers every week. And I can tell you that this week, actually, I think it was at the tail end of last week when these numbers were from. I'm just pulling this up. Bear with me one moment. My computer's being a little sluggish. The low intensity residential, of which there are 28 beds total between Grace House and McGee House. Grace House was at 67% utilization, and McGee House was at 75% utilization. And because their numbers are so small, like one more person could really push the percentage up.
Sure.
So.
Sure. Okay. All right, so before I move on to public inebriate, other questions about this low intensity, high intensity. I was just cross-checking with H13, and that really did focus on home and community-based services. It does reference short and long-term substance use services in there. This, I guess, maybe vendors, because I would have thought that would have been covered in H13. But the folks downstairs want to do their own bill, so that's fine. Does anybody else have any questions about this piece? Go ahead, Representative Bishop.
Yes, hi, Doug Bishop from Colchester, and I'm just trying to get a handle, and excuse me if I'm sort of mixing up my understanding, if I'm confusing my understanding of different levels of treatment. A constituent shared with me a letter that was sent back in August to Governor Scott with concerns about the availability of treatment. This was a letter signed by judges, magistrates, providers, et cetera. I'm sure you're familiar with that. So if we're talking about the step down that they're talking about in that letter, is that the low intensity that we're talking about in this conversation now? Okay.
Yes.
Correct.
That sounds like that has in fact seen growth with the McGee House and since this time of this letter.
Mhm.
Okay. Thank you for that clarification.
Okay.
Could I just add one point to that though? Because I
Please.
do want to just acknowledge that, even though we have different pieces of the system and we're working to build those, it's not perfect. And so that's why we really tried to put together a proposal that showed the continuum of care and how necessary it is for somebody to be able to move along that continuum, because this is a chronic illness and it is recurring, and people need to be able to access different parts of that continuum at different points in their life, including intensive recovery housing, which we've talked about in this committee, that hope that we had to increase those 15 beds where somebody, once they finished their residential component of their treatment, where they could go and live in sobriety with support for as long as they need to in order to be successful, and then return to whatever community makes sense for them to return to, including aftercare navigators, to make sure that as people are moving between these different components of the system, that they don't drop and they don't fall. And additionally, we really wanted to make sure that any residential treatment provider in the state of Vermont is offering the entire continuum of residential treatment, because we know it's going to be most successful if it's sort of wrapped under one umbrella and people can move fluidly, just like we're seeing them do at the Recovery House organization in Rutland, or people have asked about Granite Recovery in New Hampshire. Same concept, like really being able to move fluidly within that system based on your needs is really critically important to success, because like the Deputy Commissioner said, the longer you're engaged in this treatment, the better the outcomes are. And so we need to make that engagement easy for people. And so we hear still access is a challenge in the community. And so we're trying to think about other ways in which we can improve access. It's those building blocks plus the connectivity of the continuum that's really so critically important.
Yeah, and I'll just add as well that not everybody not everybody who engages in substance use treatment goes to residential treatment. There are many, many people who start treatment at the outpatient level because that's what is clinically indicated. So I don't want there to be this assumption that everybody goes to residential and then you step down. Many people start their treatment not even going to residential. And I really, like Monica said, we really want to build this continuum. I will say that there is availability in the high intensity residential treatment programs. We consistently see utilization hovering between around 60%. So we need to better understand what those access issues are. And I think that some of it is that people assume that they need residential treatment, and when they have a clinical evaluation to determine their needs, they're found that they don't need that highest level of care. And I think it's a misinterpretation that there isn't access.
Thank you. So thinking about access and thinking about the system of care and what the capacity should be, what is it that you believe that the health department believes our capacity should be? So, and then sort of keeping in mind that you said it's most effective when they're kind of all contained within the same organizational structure. And also knowing that Valley Vista is just condensing and not expanding. And they are kind of like at one end of the treatment. I'm just wondering, are there any plans to further expand the lower level of treatment or the higher end of treatment? And knowing that Valley Vista has had some financial problems and wondering about what their stability is at this point in time, knowing that they've, made some efforts to condense, and I'm, presuming addressing overhead issues. And I know that they've been in some sort of planning process with the agency. So could you speak a little bit to, whether you see them in the future, maybe down the road expanding into the lower level of residential support?
We have talked with them about that. And I think just given the sort of organizational changes that they're going through right now with consolidating the Virgin's location and clientele into Bradford, I think that they're pretty laser focused on that right now, but we will continue those conversations once sort of the dust settles from that. But ideally, we would have within the same program or within the same organization would have those different levels of care so that, like Monica said, people can transition a little bit more smoothly. It's if somebody's at Valley Vista, Bradford, to then go all the way to like Wallingford to get to the 3.1, may not be very realistic. So yes, we will be continuing conversations about that. And Monica, I don't know if you have any more to share from the agency perspective around the work that they're doing with the agency on their financial situation.
Okay, thank you. Representative Donahue.
I'm wondering if you could speak a little bit to the episodic payment mechanism and whether or not that sort of implicitly puts pressure on struggling facilities to shorten lengths of stay because they're losing money at a certain point for longer, even if it's clinically eligible. They might kind of like, well, I think they're ready to go.
Yeah, I can speak to that, and then Monica certainly chime in. So when the episodic payment was designed, so it takes into account different variables. So it looks at their diagnosis, because some substances are more, specifically alcohol, is much more intensive to treat. And so it looks at that, and it looks at, any other comorbidities or complicating factors. And so the rate is determined by those things. Once somebody is in for 3 days, the episodic rate kicks in. So those first 3 days are paid on a per diem basis, and then the episodic payment kicks in. It's like I said, some people leave after 1 or 2 days, and we don't want to pay that full episodic rate for 1 to 2 days. It was designed such that it would take into account that the shorter stays would and the longer stays would balance each other out. So, and Monica stated at the beginning that that's one thing we're going to be looking at with the rate examination, is to see if it's creating perverse incentives. But I think you'll see when I share that slide deck I referenced earlier and the length of stay data that there is a pretty wide range. But that is certainly something that we're going to look at.
Thank you.
Monica, I don't know if you have anything you want to add to that.
Yeah, I think the only thing that I can add is I think the 14-day misconception may have been born out of that original payment reform effort. And we were looking at the average length of stay, and we were looking at all of this data to help inform this episodic payment. And
Because I'm sure
that
it's not coincidental that the averages all are 14 days.
Right.
right. And so we were looking at that. So, okay, that might be an appropriate benchmark. Recognizing that some people, again, longer and some people not quite as long. And what's interesting is since we've shifted to the episodic payment, and there have been actually quite a few rate increases baked into that episodic payment. I think last year was maybe 38%. Baked into that episodic payment, we haven't seen the length of stay change considerably. The average has stayed roughly around 14 days. Again, Deputy Commissioner Doherty will send you all of the data, but just recently we've seen a little bit of an uptick in the length of stay. So again, that could be aligning with the complex substances that people are using in a polysubstance manner, that could be increasing complexity and length of stay. So, but that's very fresh data. That's just in the past. That's just in late 2024 and even early this calendar year.
Thank you.
And we, committee members, we do now have the slide deck that was,
Yeah, I
Really,
cheated and was looking at
You
that.
looked- Me too, I was
That's what
too.
brought me the question on episodic payments.
Does everyone have it?
yeah,
Yes.
we all
Okay.
have it now.
It's on
so-
page 13 was the basis of my questions.
Okay, and we have seen a number of these things we've probably taken more testimony on this subject up here than they have in health and welfare,
Yeah.
so a lot of this is familiar to us. Other questions on this high and lower intensity residential treatment before we move on to public inebriate? Any other questions? Okay. All right. So downstairs, or at least the witness reported here, and I think I confirmed with the chair of health and welfare that they actually didn't take any testimony on the section, the last part of the bill about the public inebriate program. And I'm not sure if we should have, I'm presuming that you have something to say about it, but I didn't know also if we should be checking in with mental health, because I know that they're not all in designated agencies, but I know for instance, in the last year and a half or so, the Howard Center and Lamoille County have both closed down their public inebriate programs. And when talking with folks from Vermont Care Partners, this kind of came up as a surprise to them. And so I'm just wondering if you can talk to us a little bit more about that last section of the bill.
Sure. So for many, many years, there has been this sunrise provision, and it just keeps getting renewed. So when somebody comes to a public inebriate program, often brought by law enforcement, if they are combative or uncooperative or just not safe for them to be in the program, then they are taken to the Department of Corrections until they are well enough to be released. The sunrise provision would be that it reads, and this isn't verbatim, but it reads that once that provision sunrises, that instead of going to the Department of Corrections, that they would go to another secure facility that is not the Department of Corrections. And the problem is that there are no secure facilities outside of the Department of Corrections. We don't have local jails. We don't have county jails. And so the only alternative would be for them to take these people to emergency departments, which also are not secure locations. And we don't want to be filling our emergency departments with these folks. So the real issue is that there's no good alternative. And it is challenging because DOC doesn't have official custody of these folks, but they're there for a pretty short period of time. And so we had recommended that sunrise be repealed because there is no alternative place to bring these folks.
Representative Cole and then Representative Donovan.
I was just thinking aloud, sorry.
Okay.
Thank you for the information. My understanding is that there was at least one or two, some alternatives, especially at the Howard Center. I know
They closed.
Yeah, exactly. So I'm just saying that there were alternatives. Yeah, so.
Rutland and Addison County, I thought we had.
Well, when we asked the question of the
So-
witness.
Yeah, so sounds like that was likely a funding problem, but would be interesting to compare what we're spending at like DOC on this and where we could choose to spend that money. It's-
Well, even when Howard Center was open, they were still taking people to corrections.
Oh yeah, I'm not saying that that's, you know, the only one or the other. I'm just saying, you know, that's one of our options. Or it could be if we as policymakers would like to make that choice. So I think more information on the numbers would definitely be helpful about what we're spending right now on that. And I guess that would be a question for DOC. But
And I think one of the challenges, it's a really good question, is staffing. So you need these things in close proximity when you need them, and you don't need them when you don't need them. But then how do you staff them?
Mhm.
So when we're talking about a place where we have limited workforce and a rural state, but we need access to some of these things in close proximity, it's like, what do you leverage that you have access to that's open 24 hours a day, 7 days a week? And the partnership with corrections has actually been, it's been great.
Mhm.
Because we're partnering with them a lot, recognizing that this was in our continuum of care. Let's offer residential treatment in corrections. That was part of our proposal because people are there. MAT is great, but we know that some people need more than that.
Mhm.
While they're in the corrections, why not take advantage of that time and set yourself on a good path? So, the partnership hasn't been a bad one. And we did find that, same with the merger of the crisis beds and the mental health crisis beds and the PIP beds, the idea is we should be able to treat these individuals in a co-occurring manner, and it helps us utilize our staff in a much more efficient way. And a crisis bed is not helpful if it's open 5 days a week for 8
Right.
hours a day.
Yeah.
Got to be open 24/7. And so how can we cross-train these individuals that are supporting people who often have co-occurring illness and disorder anyway, to support them so that we can have increased capacity overall throughout our system?
Yeah, and I will say with respect to the Howard Center, Bob Bick testified, I believe it was in House Corrections Committee back when after those programs closed. He said, it doesn't matter how much money you give me, I can't staff this program. It's really difficult work. There's a workforce shortage. The complexity of the people that were showing up in that program were beyond the skills of the people who were working there. It's often an on-call environment. And so that's not really attractive from a workforce perspective. So it really wasn't about the money. It was just a much more challenging workforce environment, as well as the complexity of the individuals who are coming in.
Okay, go ahead, Ann.
Yeah, I have a couple of connected questions. First of all, again, going to data, do we have, I mean, we've heard a lot in the last couple of years about concerns, hospital concerns over workplace violence in the emergency rooms and so forth. And one of my concerns is the way that gets addressed, particularly in terms of recent legislation, is those folks get arrested. So they're not currently, under a current law, public inebriate, you're not arrested, right? You're brought somewhere, but you're not. But if they're in the right,
Yeah.
but in the emergency room, that's how you could end up. Is there any data on how many people currently end up in the emergency room and end up being arrested?
Not that I am aware.
Okay.
We do have data on disposition of people in public inebriate programs, whether they end up staying at the program, whether they go to corrections, or whether they go to the emergency department. And going to the emergency department would be in the case where there was a medical issue that needed to be addressed. But I don't know if we have any data on the sort of public safety side around how many people are being arrested because of violence in the emergency
But I'm
department.
talking about, if law enforcement has picked up a person and there isn't a public inebriate bed, because we know we have very few, then it doesn't require that they have a medical condition. They're going to end up in the emergency department.
No, they'll probably end up in a correctional
They'll go in
facility.
corrections because they don't have a, but if I guess what I meant, if we don't have corrections, then and we don't have enough public inebriate beds,
Yep,
then the outcome is going to be they end up in the emergency department.
yep, it certainly could be. If we didn't use corrections, there will be
Yeah.
more people showing up at the emergency department.
So the second part of my question in terms of, what would this look like? Is to what degree has there been conversations with the designated agencies about, I know I saw some things about a merging of mental health crisis beds and
Yep.
public inebriate, which a lot of people would see as a pretty significantly different skill set and involvement with folks who might be in that 1 or 2 bedroom program. What has been the dialogue with the designated agencies who are running crisis beds?
Yep, so we're DMH and the Department of Health are actively working on that and have had conversations with some of the DAs. So we actually have 5 public inebriate beds that are not located at DAs. But we're actively working on sort of that proposal. And the idea is that we would start, I believe the plan is still that we'll start with Northeast Kingdom Human Services. And then over the next year, 2 years, we will have all of the DAs with mental health crisis beds, sort of merging that into, to be mental health and PIP. And it is some of the same
Yes.
type of
Yeah,
staff.
I know.
Yeah.
Okay, so I have I guess a couple of questions. How long I'm thinking about transportation, I'm thinking about all these things because correctional facilities are not necessarily located, except for Burlington and downtown, metropolitan areas where you can get public transportation once you're released. How do you deal with transportation and how long are the stays typically at DOC when folks go there?
Yeah. So transportation is a huge issue. And typically it's law enforcement who is transporting someone from the PIP to the correctional facility. And that's an issue. So they could be taken off of patrol for, depending on how far away the closest correctional facility is, they could be out of commission for a little while. So that is certainly an issue. As far as transportation from DOC back to their home community, I think we would need to hear from DOC on that. And the stays are not long. The stays are just long enough. It's typically like 24 hours at the most. So by the time someone is sober enough to leave and not be, deemed a risk to themselves or others. So it is not like multiple days or anything like that. It's just until they're sober enough to leave.
And do you have data on like how many bed days that there are per year utilizing the correctional beds versus the public inebriate?
I have data on the number of people who come through public inebriate and then end up going to corrections. We would have to talk to corrections about the number of days that people are actually in the facilities.
Okay. I'm trying to get a sense of volume, trying to get a sense about how many, where the locations, we're going to have designated agency folks in, see their thoughts about this combination of, public inebriate and emergency access. So it would be helpful if you had some data
Yep.
about the public inebriate program.
We do have that. And-
Okay.
Yeah, so I can send that to you all.
Okay, thank you. Go ahead, Representative Nielsen, and then Representative Donahue.
Thank you.
Oh, and Representative Cole, sorry.
I don't really understand this conversation. People are trash. Why don't we just lock them in a jail cell until they straighten out? Why are we putting them in beds?
Beds is another way of saying in Department of Corrections, they're putting them in jail.
Thank you. Okay.
It is. I figured.
Not
Right?
all of them, but just those who.
Those ones that go to corrections are going to a correctional center.
Yeah.
Thank you.
You're welcome. Representative Donahue and then Representative Cole.
Yeah, I'm sorry. I keep getting confused with the double negatives in terms of a sunrise. So
I know.
current, just correct me, I'll try to lay out. Current law is that somebody is picked up, they can be brought to a whatever it's called, a public inebriate bed. Or they can go to emergency room if that's what the need is, or they can go to a correctional center. And my understanding, if I remember from reading it, or if it's a minor, they can be brought to their parents.
Yep.
And the proposal would eliminate the correctional option. And we would then have the other options would be what would remain.
So there is currently in statute, July 1st, the option of using the Department of Corrections to hold somebody who was, not appropriate for the
Right.
public inebriate program. That option would go away
So what this
if we
bill
did nothing.
right, so this bill is proposing to leave that option in place,
Correct.
not to, okay, so it is yeah. Thank you. I must say, we haven't talked at all about the option of bringing a minor to their parents, which,
Yeah, that won't change.
yeah. Well, that was the direct cause of a young person's death in Northfield, so that has always given me some concern. Having the police bringing the child home instead of bringing them to a hospital or treatment. So.
Representative Cole?
You spoke a little bit about staffing earlier and like how you said that, I don't know, I guess the staffing ability of the prison was more apt or able than something that were to be outside like the Howard Center. I do think that prior programs actually were more expansive than Monday through Friday, and they were overnight too. So as an alternative, so just don't want people to think that that isn't something that existed. But my question for you is, you also mentioned something about recovery programs, or I don't know if program is the right word, but recovery guidance in prisons that you said that could be administered. Or like
Offered, yeah.
offered, yeah. So I wonder if you could speak more about that, because that's not something I am familiar with or have heard about in our carceral facilities, especially with alcohol. I mean, we hear all about the MAT program constantly because it's heavily used
Yeah.
in your facilities, but would love to hear about alcohol in this case.
Are you talking about the incarcerated population or this?
No, I'm talking about folks who spend the night because they're public inebriates.
Right. So certainly DOC has, information, and they have resources that they can refer people to once they leave. It's challenging because they are not officially in the custody of the Department of Corrections. So, and they're not going to start treatment when they're just there as a PIP.
Yeah, no, I didn't assume that. I just didn't know if there was protocol. Like, is there recovery sort of adjacent protocol? Like, okay, if this person's in here for this very specific reason, we're gonna, as an officer, we're going to provide you, or at least make you aware of certain resources.
You referenced earlier, Kelly, that I think it was you, Kelly, about referral to substance use programs. When they were in the correctional facility.
Yeah, and certainly, so typically people are showing up at the PIP, and PIPs, that's one of their purposes, is to connect people with resources. But if somebody is incredibly intoxicated, that's probably not the time that they're going to be either able to absorb that information or willing to hear that information. So certainly, I believe, and I can confirm with the Department of Corrections, that once those people are released after, 12, 24 hours, whatever it is, that they're providing people with those resources, but I don't know exactly what they're doing. I don't know, Monica, if you
Yeah,
have insight into
Could
that.
be interesting to see like the written protocol, if there is any, just for our understanding. for this.
We need corrections, right?
I know.
Yeah.
But
We're obviously taking more testimony on this than they did downstairs, so go ahead.
yeah, a
Representative
bit of
Donahue.
a follow to that, because I know that a program that has been perceived at least to be extremely successful precisely because it's at the point where the person is in major crisis, there is when they are in the hospital because of, an overdose or severe intoxication, so forth. There's peer recovery coaches,
Yes.
because that is the moment where you have a really good shot. So I'm wondering, and again, you may be the wrong folks, but I'm assuming there is probably not that when somebody is held in a cell in corrections. They don't have a peer recovery coach program that comes in to say, I can help get you to treatment. I've been there, can I work with you?
Yeah, that's a fair assumption, although we do have peer recovery coaches going into
That's-
Marble Valley, and that's
That's
gonna
for
be-
long-term though.
That's
Yeah,
for
that's a whole
long-term.
different program. I'm familiar with that one. Yeah.
Yeah, it would be
Um,
best to ask DOC what their protocol is. in
Yeah.
terms of-
Yeah, we will. So I guess I want to challenge a little bit what you talked about, Kelly, around it wasn't about resources, because we did hear at Joint Justice Oversight, we took testimony on when the Howard Center in Lamoille County were shutting down. And in fact, at the time, at least in Lamoille County, they said, yes, we would reopen immediately if we had sufficient resources to do this. So I guess and I think the Howard Center folks said the same thing. I guess I would challenge that. I feel a little bit like we're, failing to build the community system, and then what we end up doing is backpedaling and relying on the institutional system. And, I'm not sure that's the best public policy. And so it just causes us pause, I guess I would say. We also don't want to overburden emergency rooms at hospitals either. So it would be helpful to have some data on which to make a decision. So like how many PIP beds are there in the community? How many bed days are used there? How many bed days are used at the correctional centers and where, that kind of sort of basic stuff.
Emergency rooms.
Right. Yeah. That would be very helpful.
That's a fair challenge. And I think that's also part of the reason why we felt so strongly about building out that intensive recovery housing as well, because what we're trying to do is create opportunities for people to recover and gain support outside of and after their residential treatment, so that there's not that recidivism and they don't end up back in that part of the cycle. So, it's both ends. It's really both ends of the spectrum.
Relapse.
And I
Yeah.
hear you, in a perfect world, we would have that type of access to those resources connected to those PIP beds, and they would be able to provide that level of, safety measurement that they can at corrections. And you have hard decisions ahead of you in terms of finite resources where you get value.
Yeah, I mean, exactly. And when people utilizing substances relapse, not recidivate, but when they relapse,
Thank you.
when they relapse, and we know that journey is a series of ups and downs, and step back before you make two steps forward again. And so it's an expected thing. And our committee did recommend forth that the proposal that was presented in the governor's budget, it didn't make the cut downstairs, but so I recognize what you're speaking of. But on the public, I also don't want to kind of confuse the issues either, because the public inebriate is a little bit different. Sure, you would love it, if it's somebody who is kind of like continually cycling in and out of that situation, you would hope we be able to intervene at some point in time, or that they'd be ready at some point in time. But we just we'll do our best for sure. So I think that we will have Department of Corrections in, so, maybe between the two of you, you could give them a little insight into our conversation here this afternoon. And so they could be prepared to answer some questions about to what extent their facilities are used and the like. That would be very helpful. And then we'll await some data that you're able to produce on the utilization of this. And just so you know, we are going to be having folks from Vermont Care Partners in to talk about the sort of proposal to merge public inebriate and the emergency, 24-hour emergency. I mean, I get the concept, but I think that, some people might have differences of opinion about whether it's a good idea or not. So, but I appreciate the creativity and trying to think about, how do we assure public inebriate services are in as many communities as, we can without breaking the bank at the same time. I get it.
What's 24/7 available? Yeah,
right.
Not a lot.
Yeah. And it's, a lot of time spent with people, nobody there. And then you have staff and you're wondering like, what are we doing with the staff? It's, so I get the concept.
Yeah.
Anybody else have any further questions for the witnesses this afternoon? Great. Thank you both for being here and for being so willing to come on such short notice. We really appreciate it. We'll be in touch.
Thank you.
Okay. Katie, while you're here, would you be willing to pull up the statute that they're repealing, that is repealed here, just so we can see that language?
I mean, it's basically like saying, well, we haven't been able to resolve this, so we are giving up.
Yeah.
We kept pushing it down the road because we weren't able to do it yet. So now we're saying we surrender.
Well, I'm not sure we will, but
No, I'm just saying the bill would say.
That's what that says. Yeah.
Yeah.
Yeah. To be, fair, I guess is the word. They're trying to look at solutions and trying to figure
Yes.
out ways. And so why would we repeal it right now if they're still in the process of looking at
Exactly.
solutions?
If we have to kick it down a little bit, that's one thing. I don't even like that, but if we have to, but to just say repeal it, then all the pressure's off.
That's kind of what I feel.
Yeah.
Yeah.
So,
I'm confused about like like you said, capacity will be very interesting to get some data on, but like we keep talking about the stress that is on our jail system right now in our carceral facility. So I'm confused as to why they're like wanting more. I don't know.
well, corrections
I
may
guess
not
that's
be
not-
wanting to.
No, yeah, totally. I just
From them, yeah.
That's why I'm interested, like,
the staffing piece, like they don't.
Springfield is
they're not
severely
staffed.
understaffed.
Yeah, exactly.
and-
So I don't know why they're saying, oh, other things aren't staffed.
But I think, and as I think we're going to have someone come testify from Colchester, there's also stresses on local communities and law enforcement locally.
Oh, for sure.
Because they're not
Yeah.
provided, currently in Chittenden County without
For
an
sure.
option. They're left trying to figure out what to do without,
Do they take them to St. Albans?
I don't know that. I don't know whether it's St. Albans, presumably, because
I mean, that'd be
Unless it's-
unless they're taken, I don't think they're taken to the women's prison, but.
yeah, unless there's some carved out space at Chittenden Correctional, but I've not.
Yeah. So we'll add Lori, Department of Corrections, to our list of witnesses. Even though Brendan didn't think we needed to have them, I thought that would be different. I thought we might have a different take on that.
Yeah, I think we do. I think you're right.
I'm not sure who it would be, but you can start with Commissioner Demmel and he can decide who he wants to have come to, about the public inebriate stays. Okay, let's see what,
In the interest of full disclosure, I have to leave in about 3 minutes.
okay,
Okay. I will
that's
make
fine.
my comment afterwards.
So it's 2 sections. It's
Okay.
with the Office of Legislative Counsel, 4810 and 4811. So 4810, this is effective until July 1, 25. And then we have another 410 in statute that is effective July 1, 25. So the first one, the second one swaps out for the first one.
First one, okay.
Most of the changes that make them different are in sort of the second half of the statute. And then there's 411, which has never taken effect. It takes effect July 1. a person who has not been charged with a crime shall not be incarcerated in a secure facility operated by DOC on account of persons intoxication.
Okay, and that's the one that that's the part they
That's
want to
the piece they
repeal
wanna
altogether.
repeal.
Yeah.
They want to repeal 10 and 11.
10 and 11.
Yeah.
They want to appeal the transfer
Repeal,
phase of the.
Okay.
Okay.
All right. We'll spend a little bit more time on this. So thank you, Katie.
Do you want me to send a link to?
That would be awesome.
Yeah, okay, perfect.
Then we can, instead of going looking for it, Lori will send us the link and we can read it on our own, I think. Yeah, you had a comment, Ann?
Oh, yeah, I was trying to remember. Well, yes, just that there's a little overlap going on here in terms of the health committee being aware that that the designated agencies, that whole system is in the healthcare committee, the crisis beds.
Yeah.
Operation and all that.
Yeah.
And if they're gonna propose merging public inebriate, that they probably ought to have a heads up too. They might have
Yeah.
thoughts on that issue.
Yeah, I've asked Amy Johnson to, rally a couple of her folks who are involved in these discussions, because this was kind of the first they heard about this.
Yeah, I had no idea it was coming up.
Yeah, so.
But then I hadn't paid attention to the date, it's like one of those
Right,
trigger dates. We
right.
keep kicking it down the road.
Okay, and then I'll talk to Alyssa or Chair Black around, depending upon what we decide to do with this. I'm sure they would be fine if we keep extending the date out, but the plans, I'll just give her a heads up because she might not be aware that there's. those
Probably
kinds of
not.
discussions.
Yeah.
Yeah. Okay, all right, folks, so tomorrow, it's not on there because that's before we changed it. Well, let's just take a look at tomorrow's agenda before we take off here.
Yeah. Looked at it before, but
I know.
remember it.
So we have floor, obviously at 9:30. There's nothing on the floor, so it'll be a quick floor. I don't know how many introductions there'll be and, all of that kind of stuff. But we are going to take up S36 again. And we're going to be hearing from the folks at Recovery House, their medical director and executive director. And we're going to be hearing from, Northeast Kingdom Human Services. So that's just about what we were just talking about, the emergency beds and use of PIP. So we'll do that in the morning, and then after lunch, we will be talking to the general counsel of the Department of Health. And I'm just trying to, what's that about? That's Eric's bill that he did. It's the miscellaneous amendments to the healthcare statutes. So it's a miscellaneous bill. It's a cleanup bill. So, and then you'll be off for the weekend. So
And we haven't walked through that, right?
we have not
Yeah,
walked through
okay,
that.
That's fine. I can
No.
take a look.
Yeah. Okay. And we're not able to have Katie in the afternoon tomorrow, right? Just double checking. No.
No. I sent her an FYI,
Okay.
so she knows about it.
Okay. All right.
She can come, she will.
All right. So we'll have a walk through that, but we'll hear from them about why they think the bill needs to be enacted.
Right.
Anybody have any questions about what we're doing?
Nope.
Okay. Does anybody, are there any volunteers around reporting out? First, I'm gonna ask, I wrote H36 and it's not, it's S36. S36. So you're getting a sense of what S36 is. It's not honestly too complicated, the first part of it. The second part of it might get a little bit more complicated on the public inebriate stuff. So you don't have to give me an answer now, but what I'm putting out there is there's an opportunity for people to maybe perhaps give their first bill report. Also thinking about H92 and the Human Services Board. I don't have any official assignments, but I'd like, these are a couple of bills that they're good, I think going to be relatively straightforward. Not too long. If you want to dip your toe in the water a little bit, then you can do. And H92 is something that our vice chair is going to be leading our markup on H92. Getting some experience. Okay,